Hello, and welcome to another episode of the CSA's podcast, Vital Times. I am your host, Rita Agarwal, and for this episode, I decided to go back to the basics. I wanted to talk about something that all anesthesiologists care about and that still often cause, at least for me, anxiety. And that is airway management in the challenging patient. I invited a former colleague and friend of mine to join me for what I hope will be a fun, educational, and perhaps somewhat scary discussion. Dr. Juels is an associate professor of anesthesiology at the University of Colorado School of Medicine. She is the director of quality, safety, and improvement, and the director of OB Anesthesia, and an attending physician at one of the top trauma hospitals in the country, and that's Denver Health Medical Center. Dr. Juels has also lectured and presented workshops nationally on difficult airway management and is an expert consultant for the Colorado State Medical Board. She has also cared for and written about caring for many patients with difficult airways, including awake fiber optic intubation. Welcome, Dr. Juels.
Well, thank you for the introductions. I do want to mention that actually Dr. Agarwal was one of my mentors when I was a resident and got me to go into academic medicine. So it's nice to join you to do your podcast today.
Oh, great. Well, thanks for coming. I wanted to start by asking you about some of the challenges that you've encountered with patients and to share some of your experiences. And then later, I'd like to ask you about some tips and tricks for successful awake intubation, including airway blocks.
Well, the Denver Health being a big trauma center, we do see a lot of airway emergencies. And some of the challenging ones that we've seen have been gunshot wounds to the face or to the neck area. And we've also had one patient that came in with a facelift that had gone bad, and she had a hematoma all the way through her cheek, all the way down through her neck, and came emergently to the operating room to get intubated because she was starting to get short of breath and losing her airway. So I always try when we get called in the emergency department with these airways. First of all, if we get called from the emergency department, we know it's not good. So always be prepared for that. And as best as
Sorry to interrupt. So in your practice, you don't routinely get called down to the emergency room to help with intubation?
No, at Denver Health, the emergency department handles the majority of airways, even in traumas. And usually when they call us, it's because they are concerned about the airway or the patient they know will need an awake fiber optic intubation or ENT involvement. So we try to coordinate with the emergency department to bring the patient up to the operating room. And most of the time we have general surgery, our trauma surgeons.
So does your team routinely go down to the emergency room for intubations?
No, the emergency department at Denver Health, their residents and faculty handle the intubations, even with the trauma patients. We just get called down if the emergency department is concerned about any airway that might need to be an awake fiber optic or that ENT is going to have to be involved with. So usually they're pretty good about calling us just when something needs to come to the operating room. And usually that's an awake fiber optic. So we usually resolve pretty quickly to get to the operating room with ENT or general surgery in case there is an issue that they can quickly go ahead and cut down on the neck. And like I said, some of the challenges, the facial was an unusual one. There was also a patient that had a 2x4 that landed right into their neck. And actually that awake fiber optic was then down in the emergency department because we felt the patient was not stable enough to come upstairs. And gunshot wound to her.
Wait. You gotta tell me more about this one. 2x4 to the neck. So was this like a 2x4 fell on them, or are they in a fight, or do you remember? You may not remember.
No, I absolutely do remember. It was one of my colleagues that took care of the patient, and this patient was a construction worker, and the 2x4 basically went flying into his face and caused a significant amount of damage into his face, down through his neck, and even he had a pneumomediastinum that developed through there, and he was having pretty acute neck swelling and was getting quickly short of breath. And he was actually bleeding quite a bit. So the decision was with OMFS, ENT, general surgery, and the emergency department physicians downstairs in the emergency department doing an awake fiber optic. One of my colleagues did a very nice job numbing the patient up and doing that awake fiber optic down the emergency department, actually walking through with the emergency medicine resident doing it, and that was very well done. So we do see the bunch of challenging airways. The one that actually was shocking is we had a patient that came in probably about a month ago that had strep, and it progressed pretty quickly. And the patient came into the emergency department got very short of breath, and they decided to call anesthesia and ENT and general surgery down to the emergency department because they were worried they were going to lose the neck. And the patient progressed very quickly to almost not being able to breathe. So I was not me. There were 3 anesthesia attendings down there that attempted to do an awake fiber optic. And when they went actually through the nose, because it's a little easier access, they saw that there was an extreme amount of swelling in the back of the throat, and they're not going to be able to get an ET tube in there. And the patient started decompensating. So ENT just went ahead and cut the neck. And they were only able to put a 4.5 tube down this lady. She was a small lady, but still 50 kilos, and rush her up to the operating room because the patient's awake through all this. And they did numb up the neck in order to go ahead and make an incision. And through a cricothyroid membrane, they went ahead and put a 4.5 tube, came up to the operating room, which I took over the case, and went ahead and expanded that into a regular trach for this patient once she was asleep. So there are all kinds of airway challenges. And the most important, if you can keep that patient breathing on their own, that will be the best way to be able to handle, because any breathing they do will be better than trying to put them off to asleep, taking away their airway reflexes, not be able to get that airway.
So the patient with the strep, was it strep epiglottitis or pharyngitis, or
It was a
did
strep pharyngitis.
pharyngitis? Wow, I
Yes.
don't think I've heard of an adult. I know I've definitely heard of it in the past in children who've developed really significant airway emergencies from that. But that's pretty. And
Pretty unusual.
she was breathing spontaneously through all of this, or trying to.
Yes, she was trying to breathe spontaneously. It was obvious that she was decompensating, and she was breathing on her own while this 4.5 tube was put in, and she was transported by many physicians to the operating room. And we actually went ahead and did an inhalation induction for her and put her off to sleep. And then once we felt that it was comfortable, that we had everything under control, we did go ahead and paralyze her because she was bucking significantly when they were trying to convert that to a regular trach. But that was at a point that we all felt, okay, she had a slim neck, and if we went into problems, ENT felt they can widen that quickly and get something bigger through the hole that they had made through the cricothyroid membrane.
And you did inhalational induction because that way you could keep her breathing spontaneously throughout. Okay.
Exactly, just because I wanted to make sure we had some control of the airway until the ENT surgeons were prepped, draped, and felt that they had control in case they needed to make the incision bigger and put a trach in. I wanted to make sure that she was spontaneously breathing is better than no breathing, even
Right.
through a 4.5 tube.
And through a 4.5 tube. Well, you had a case that recently that you both, I think, written about and presented about of a patient with a tracheostomy that didn't go as planned. The anesthetic didn't go as planned. Can you share a little bit about that case?
No, absolutely. Because, like I said, most of the time, yes, we get scared in the operating room when we have a difficult airway and we lose an airway, and we have mechanisms that we can use. For example, putting an LMA in, getting the gyroscope, waking the patient up if we can. And so those, even though we get nervous about it, it seems that we can control it. If we know about difficult airway, we can do an awake intubation. This particular case took me very much by surprise. It was a young man, he was 18 years old, that had fallen through an elevator shaft about a week prior and had multiple broken bones. And they decided to, because he had multiple procedures, to go ahead and do a trach on him. And he had a trach in place, and I took care of the patient on Friday, and everything went very well. So on Monday, I was assigned to do the case as well. And I asked the resident, had anything changed over the weekend? And the resident proceeded to say, no, everything was the same. So the patient was at that point spontaneously breathing, but still on the ventilator. They just had some pressure support, and we transported to the operating room with his spontaneously breathing, just putting an ambu bag with some oxygen to take him to the operating room. Then when we started inducing anesthesia and he started getting apneic, the patient's capnogram became very shallow. And I tried to hand ventilate him. It was very difficult to hand ventilate him. He started desaturating a little bit. So I started hand ventilating some more, and it was very difficult to hand ventilate him. And now he was definitely, the capnogram was very shallow, and it was obvious that we were having problems ventilating him. So I thought there was something wrong with the trach. So I went ahead and tried to suction it. It was difficult to advance, but it was very dry. So at this point, the patient became apneic just from the anesthetic that we gave him. And I went ahead and put more air in the cup, thinking we're having some kind of a problem. And it was just hard to ventilate. So I said, okay, well, there's something wrong with this trach. So I went ahead and pulled it out and put an ET tube down the hole that was there with the trach. I put an 8.0 tube where that seemed to go in very easily. And now I absolutely couldn't ventilate the patient whatsoever. The patient started desaturating. He went down to about 30%. He was turning blue and starting to get bradycardic. So this is one time where I'm sitting, well, wait a minute, we have a trach. It's a definite airway. And I just was sitting there going, I literally do not know what to do with this patient. So then you just think, well, ABCs, what are you going to do if a patient you can't ventilate? So I decided to intubate from above because I really could not think of anything else to do. And while I had luckily it was a very easy intubation. And when I went ahead and intubated, I had the resident pull out the tube thinking it was going to be in my way. So went ahead, inflated the cuff, ventilated the patient, everything was fine, SAT went straight up. So just as a side, this is an ortho case, and the orthopedic surgeons were like, okay, we can operate now. And I was like, well, wait, we need to figure this out first. So I went ahead and called ENT that was not available. So we had our general surgery, trauma surgery that came right away and explained the situation. And what we found out actually was that the patient did have the trach changed over the weekend because they wanted to get the patient able to talk since he was doing better. And what they went ahead and put in is very unusual. You don't see it very often, is they put a fenestrated cuff trach into the trach hole. So most of the time when you have a fenestrated tube, it doesn't have a cuff on it. So that's kind of where I got fooled because I saw the cuff there and I said, okay, yeah, the resident said nothing changed. And I assumed it was the same. Most of the time, a fenestrated tube does not have a cuff on it, and the patient can speak around that. So anyway, the patient ended up getting a fenestrated cuff trach replaced over the weekend. The problem is
how can I just interrupt? How does the if they have a cuff, are they still able to speak with the fenestrations in place? Because I would think if the cuff is blown up, that's still
correct.
Prevents a lot of air movement.
Correct. The cuff, exactly. So for them to talk, the cuff has to be deflated.
Okay.
So right. So the cuff was deflated for him over the weekend, and we inflated it when we went ahead and brought the patient to the operating room. So the general surgeons went ahead and opened up the trach and realized it went through a blind passage. So what that means is that when they changed the trach over the weekend, when they pulled out the old trach, instead of the new one going through the same hole into the trachea, it went through a passage next to the trachea, which we call a false passage, and it was just sitting in a pouch of tissue that basically did not go into the trachea. And the mistake that was made here is that, well, two things happen. One, at our institution, when you go ahead and put a trach in, you check the position with a fiber optic scope. And you could see that, okay, it's in the trachea, how far from the carina, and you could position it correctly. When they change it, it's usually in the ICU and they don't check the positioning. So the only reason this patient was doing well over the weekend is because the cuff was down and he was literally probably just breathing from above or breathing around the cuff, the trach itself. So usually when you have a fresh trach, you need to wait. You're looking at the literature, it's usually 7 days or 7 to 10 days in order to let the scar tissue around the trach form. Otherwise, you have a high propensity of getting a false passage. So this patient had the trach replaced 3 days after the initial trach was put in. So high propensity to have a false passage. And some surgeons will wait even 10 days before they replace the trach exactly for that reason.
That's so interesting. So why do you think they went ahead and just did that? And did he have did he have facial fractures as well? As that part of the reason why they wanted to do the trach, or was it mostly just orthopedic and they thought he would have prolonged intubation?
It was for prolonged intubation. He had many procedures. He was in the hospital at this point, 2 weeks with many procedures. And, as we all know, after a while, you need to take the ET tube and change over to a trach. So they figured he was going to be intubated for quite a while. And why they changed it over, I don't know why they made that decision. I know one of it is to allow the patient to talk around. They could put a speaking valve on, but their whole point was to try to get the patient to be able to vocalize with a trach in place.
And he must have had decent pulmonary function that he was able to maintain SATs and ventilation, basically breathing through the trach hole, right? Because it's the hole in his neck that he's breathing through.
He's breathing through the hole in the neck or from above. He could be breathing through his mouth. Or with a cuff down, he could have had some of that air through the fenestrated trach going through the fenestrated trach up above, and there's still like a fistula between the trachea and this false passage. So there are many ways he could have been breathing around that nobody suspected an issue without physically taking a fiber optic, a bronchoscope, and looking through there and seeing that it was a dead end there.
Wow, that's just really remarkable. I just can't, and I think it's partly, I assume, because he was a otherwise young, healthy 18-year-old without a lot of bad pulmonary disease or much pulmonary disease to start with, that he is able to maintain SATs the way he was and ventilation the way he was, that it wasn't suspected before that. So once they, and you, again, tell me if you don't know the answer to this, but once they realized it was, and again, at Denver Health, it's oftentimes the general surgeons who are putting in the trachs. It's not always ENT, because some places it's always ENT, I think.
Right. So we actually have OMFS, general surgery, and ENT that put in trachs.
Okay.
Usually when the patient's in the SICU and it's being changed over, it's the general surgeons that do that.
Okay.
Right.
Were they able to close up? And I'm just surprised that they didn't have any resistance when they put in the new trach, because I would have imagined that, as you put in something through tissue, even if there would be some kind of resistance. I don't know.
Well, I don't know if you've ever changed a trach over before, but I remember after this getting called to the MICU to go ahead. A patient had somehow pulled out, or the trach came out, and they called us to put it back in. Well, after this experience, the first thing I did was call our trauma surgeons and ask them to meet me in the MICU. And when I got there before the trauma surgeon, and I tried to put that trach back in and met a lot of resistance. There's definitely a technique to doing it. Yeah. And then the general surgeon came in, and it was very easy because he knew the angle to go in. And there is definitely some resistance. So should they have known? I don't really know, but it wasn't as smooth as I thought it was going to be to just go ahead and slip a trach back in there. So I'm not sure, obviously, what it felt like to them when they put it in the false passage.
Wow. And the patient ultimately did okay?
The patient did great. So the surgeons came in.
That's the most important.
Well, the most important. Ortho got to operate. So the general surgeons that went ahead and put it down the correct location. They closed the false passage. I extubated from above, and while they replaced the trach, and ortho got to do their procedure. Yes, and the patient was safely decannulized. Actually, a couple of weeks later, and did fine. Yes.
Oh, that's great. That's great. What a case! I mean, that is really, because you think you have a trach, and you have a trach that's been proven. It's not like a brand new. You don't think it's a brand new, fresh trach. You think it's a trach that's been proven, that you've personally used before and provided successful anesthetics for in the past. So to have this suddenly come up, that just seems crazy. And good job in managing it. And glad the patient did well.
Well, the thing to remember too is that so one now with Epic, it's a lot easier to look and see what kind of trach the patient has. But we talk about plug and play for trachs, and it's a simple case. Well, I have a newfound respect. There is no such thing as a plug and play. And when a trach is fenestrated, it's written on the front of it, so you can go and look at the patient's trach, and it's hard to see because it's a clear tubing, but it will say fenestrated on it if it's fenestrated. And this did, I just didn't look. And the other thing to remember is most institutions do not have fenestrated cuff tubes. So don't be fooled about the fact that there is a cuff, because that can happen. And the other thing too is that if you can have an introducer, that'll go ahead and plug up that fenestration. And so you can use a fenestrated cuff tube if you need to do a case, if it's in the correct hole.
Right.
And yeah, so there are a lot of things to think about, but the most important is the one thing I always do is check and see what kind of trach the patient has. If it's not in, we have Epic. If it's not in the medical record and the nurse doesn't know, then I make sure that, sorry about that. I make sure that we find out what kind of trach is in there before I ever take a patient to the operating room.
Well, that's a great warning, I think, for everyone, and a great lesson for everyone to review, is that a trach is not just a simple, stick them on the vent and go from there kind of a case. If you don't mind, I'd like to just spend a few more minutes talking about awake fiber optics, or awake. I guess it's now, because none of our scopes are fiber optics anymore, right? They're all video laryngoscopy of some kind or another.
Right.
But you say you do a lot, and how do you? I mean, we can take like two examples, and you've shared a bunch of really interesting and scary cases already, but and I know it's a little bit different, obviously, in an elective situation versus an emergent situation. But how do you prepare the airway? How do you do airway blocks, or do appropriate numbing so that patients tolerate the awake intubation?
Yeah, and that's a good question. And one of the probably the most common that we do at Denver Health Awake Fiber Optic is a tooth abscess that has gone bad. A patient had some kind of a molar or something that was pulled, and it got infected, and they have all this swelling. So what's that?
Those are some bad teeth.
Those are some bad teeth. And so one of the examples, so first of all, the one thing I enforce to the residents is that you want to avoid secretions. So if as soon as you see that patient, give glycopyrrolate. So I usually give 0.2 milligrams, because you want to dry out those secretions. And there is one example that I think would be a good example, is a patient that had a tooth abscess that went bad, and he unfortunately let it go for quite a while, and now he's starting to have airway compromise and a very swollen left side of his face. And turns out that it was going down into the airway as well. So there are a few things that you can do to numb up the airway. And the other thing to remember is if the patient is, one of the ENT surgeons told me once that the only thing that might be keeping the patient breathing is the fact that he or she, is uncomfortable. And anytime you sedate them, you might be taking the respiratory drive away, because all of a sudden they're comfortable. So something to keep in mind when you go ahead and sedate patients is that sometimes you can't afford to sedate them. But there are different ways to do it. If you have a patient that does not have any distorted anatomy, we could do airway blocks. And it's a nice thing to have under your belt. And it's definitely something that is tested for the residents on their written boards on the in-service. And the other way is, there are different other ways to numb up the airway. But what I like to do usually is I don't feel that that the lidocaine nebulizer works very well. So what I like to do is there are different ways to do it. But the other thing to keep in mind is that you reach toxic levels of lidocaine pretty quickly. So you have to be cognizant of that when you go ahead and numb up the airway and calculate it. I mean, some patients, it might be 10 cc's of 4%. So make sure you're cognizant of that. But if I can, I try to get them to get some viscous lidocaine to gurgle as far back in their throat as they can. That's 2%, 15 cc's. I time them a minute and go ahead and have them spit that out. So that gets basically the glossopharyngeal area, the back of the throat. And another way you can go ahead and numb that is what we call a lidocaine lollipop, where you put some ointment on some gauze on a tongue depressor and have the patient go ahead and put that as far back as you can into the patient's airway, and it's going again ahead as it gets warm. As they push it back there, it's going to drip down into the posterior pharynx.
Wait,
Other way, go ahead.
is that just regular, like the 2% lidocaine ointment that you can find like lying around places?
Exactly.
And you
Exactly.
just
Yes.
soak a piece of gauze. Do you measure so to you make sure that you don't do talk? I mean,
No, that one you can
okay,
measure.
so
So it's
that
just
you
something to
can
keep in mind.
yeah,
Yes.
and you probably don't have any idea how much systemic absorption they get at
Right.
that point, but yeah, okay.
Right.
So you soak gauze in it, you wrap it around a tongue depressor, and
Hmm.
then just have them stick it back as far as they can and let it
Right.
dissolve. Oh,
Right.
that's a cool way of doing it. And
Right.
do you,
And this is all for the glossopharyngeal area. So kind of the
and,
posterior pharynx.
and you do you leave that in their mouth for a period of time as well? Is that like a minute or 2 minutes or
So usually, depending if the patient's presenting straight to the operating room or if I see him in pre-op. If I see him in pre-op, it's something I'll do the glycopyrrolate, and then the viscous lidocaine in pre-op, and then I'll have them do the lollipop as we're rolling back to the operating room.
okay.
And then
Okay.
once we're back in the operating room, I go ahead and take that take that out. Sorry. And then the other thing you could do is I have probably about 3 cc's of 4% lidocaine in syringes on the anesthesia machine. And I could do an atomizer. The LMA atomizer is the best way to go. You can attach a 4% lidocaine, 5 cc's, and take a tongue blade and try to go back as far back as I can, injecting a little bit in the posterior pharynx and
Wait,
going
wait,
a little past that.
LMA atomizer.
It's just a tube. It's a small tube that you stick on the end of a syringe, and it's very flexible and it
Okay,
bends.
okay. Yeah, it's called LMA is the brand, I think, or something. I forget what it stands for. But
Correct.
and now I was thinking, sorry, I was thinking the LMA, like a laryngeal mask airway. I'm like,
Oh,
wait,
no,
what is
sorry.
this? I've never heard of before. That
No, the
sounds so
brand. That's
cool.
the
No,
brand.
so this
Yeah.
is okay, the atomizer. So you just squirt that in the back of the pharynx as much
Right.
as
And go as far back as I can. It's pretty flexible, so you can really get it back there and
yeah.
advance it quite a bit, and they might cough a little bit. Um, so that all is to get the posterior pharynx, the glossopharyngeal area. Now, so that is kind of the area above the vocal cords. And now, in this particular patient, there were no we couldn't do airway blocks as the anatomy was too distorted. So the other thing you want to do is you have these oral airways. They're the Berman airway or the Ovasapien airway, and then oral airway that you can go ahead and stick the fiber optic and 802 can fit through as well. And you put that in the patient's mouth with some lidocaine ointment, again, at the back of it. And that kind of keeps the tongue out of the way. And sorry, I just got, it gets the tongue out of the way and also numbs up the back. So you know that the back of the throat is numbed up as well. So you go ahead and put that in there, and you put that midline so you can get past the tongue when you put the fiber optic in there.
So do you do that after you've already done the gargling and the lollipop, or is
Correct.
it instead of
Yes.
gargling and the
No,
lollipop?
you do that. So
You're not
if you're going to do
with that something back there, right? Yeah.
right. So that is after now you might not need to do all three of them because you have to be cognizant of the toxic levels. But so you could actually do a fair amount putting it through that, because now in order to numb up past the vocal cords on somebody like this patient that you cannot do the airway blocks is so you want to go ahead and tee up. So you load up a fiber optic scope, or like you said, the video scopes with a fiber optic that you attach on there. You want to load up an endotracheal tube on the end of that. And I lubricate the end of the fiber optic of the ET tube, and I lube up also the inside of the endotracheal tube to make it easier to slip through there. Now, the best tube to use is a Parker tube, and not just because that's my son's name and I think it's the best tube. But the Parker tube has the end that is very soft and also hugs the fiber optic. So if you can get a hold of a Parker tube, it's the easiest way to advance the tube and not get stuck along the arytenoids. So you go ahead and load up on the fiber optic.
Parker tube. How is it possible? I've done anesthesia for 30 years and I've never heard of it. Maybe they don't make small sizes.
They might not make small sizes for Pete's tubes, but the Pete's tubes are a little softer as well. The other one that you probably don't have in Pete's is an end draw tube. And the one with that, yeah, it has the hook.
Okay,
Exactly.
that,
So
I
you can
think it
maneuver
goes
that one. Do they
down
have
as
that for
small as
peds?
I don't think so. I think it goes down, and I don't know this for sure, but I think it goes down to 6.0
Okay.
intratracheal. I'd have to look that up. I'm not sure.
Yeah, so peds is a totally different ball game. But so I like using the Parker tube, and you load that up and on the fiber optic, and you lubricate the end of it as well. And it helps for it not to get stuck around the retinoid, especially if it's hugging the fiber optic. So what I do is I take an epidural catheter and I put it through the side port of the fiber optic and go ahead and advance it all the way to the end. Now, the other thing, you can go ahead and try to inject through the fiber optic, but it just doesn't spread quite as well. The nice thing about the epidural catheter is it has side ports, and you could go ahead and get a lot better spread into the airway when you
Oh, it
go
is.
ahead and advance the fiber optic scope. So you
Love
go ahead and now that you're all teed up, you go ahead and place the fiber optic through this Berman or Oversapien airway, whatever you guys have, and advance it until you get all the way through to the vocal cords. And then I inject through this epidural catheter, and you only need like half a cc or 1 cc. The patient will cough, and you go ahead and get through the vocal cords, and you inject another half to 1 cc, and you inject slowly as you go ahead and advance until you get to the carina. Now, patients will cough, but that's good because they go ahead and spread the lidocaine. And that's 4% lidocaine that I tee up on the end of the epidural catheter.
Wow.
And then once you get down to the carina, you want to go all the way down to the carina because it's amazing how these tubes somehow slip out and don't get into the trachea. So you do definitely want to advance it. And the one thing I tell the residents all the time is that the slower you go, the faster you go. Because these patients are breathing and you keep on losing sight. So you really want to go 1 millimeter at a time, even when you pass the vocal cord. Get so excited. Oh, there's the vocal cords, and you want to go fast.
Yeah, yeah.
Slower the faster. And it
Brilliant.
kind of became a
Vocal
joke.
cords, you kinda shove the tube in.
Yes.
Saying,
And, it's kind of the other day I was joking where the resident said, Dr. Juels, I'm not even moving. So you want to go a little faster than that.
okay.
But definitely go slower. And then go ahead and disconnect. I tape the endotracheal tube to that fiber optic at the top, undo it, and they go ahead and advance it. Now, when you get stuck, that means you have the retinoids. So sometimes you have to basically turn the endotracheal tube around, kind of corkscrewing to get past the retinoids, which, like I said, for the Parker tube, that's a lot easier. And if the patient's well numbed up, they should be able to tolerate this very well.
Really
Go
well.
ahead and advance the ET tube. And I always inflate the cup and confirm CO2 before I induce the patient at that point.
Okay. Wow. So, okay. What about if you go through the nose? How do you numb up the nose?
Well, the nose is very hard to numb up, but the one thing that I found is that works very well is one, you want to put a lot of neosynephrine. In the old days we used to use cocaine, and I'm not sure.
I remember those days.
Oh, it worked amazing, right?
Right.
But
It was
now, yeah, so we don't use it like we used to. I know ENT still has it available, but you spray the nose very well with neosynephrine because you want to basically constrict that. And actually, what I do after that is I go ahead and soak pledgets with some 4% lidocaine and go ahead and gently advance through whatever nostril you're going to use. And you advance it slowly, let it soak in there, advance slowly, let it soak in there. And it has a string on it. So you guys take some, whatever tweezers you have, hemostats, whatever you have, and go ahead and advance it as far back as you can. And just let it sit there and soak in there to numb up the airway. And then once that's done, then I go ahead and put some nasal trumpet with lidocaine ointment on there, start with a little smaller size, and then go ahead and put that through to numb it up and dilate as well and drip a little back there. And once again, unless the patient's very tall, I like to use a Parker tube as well for the same reason. It is longer than a regular tube, but still you have to be cognizant that in tall men, it might not be long enough. So make sure that it is long enough, because otherwise you'll have to use a nasopharyngeal, a tube, specifically a nasal tube, to go ahead and do that because it'll be a little longer.
Yeah. The last thing I wanted to ask you about, because you've mentioned airway blocks several times, and I agree with you. I know I feel like, and again, I'm in the peds world, so it's a little bit different because we do many, many less awake intubations than people in the adult world may do, because kids are just not going to tolerate a lot of what we're going to do. But I know the few times I've done it, we always start by nebulizing lidocaine. And I just am not impressed. I don't think it does very much. It doesn't seem to do anything. And I'm glad to hear you agree, but yet it's still often what is taught and what is done. Why do you think that is? And then tell
Well,
me
I
about.
don't know. Yeah, so I don't know why it's still taught because I could tell you that when we use tetracaine seems to work better.
Okay.
When I was working at UCLA, we used to do nebulizer with tetracaine, and it seemed to work better, but still not as well as what I would describe in the blocks, which I'm going to go ahead and describe. It's very patchy, and I don't know why it's patchy, but you get a very incomplete block, and you're going to have a patient that coughs, and you're going to make it a very
Supplement.
messy fiber optic,
Yeah.
and you're going to have to supplement or have a patient coughing. So I've watched it, and I've never seen a very smooth nebulized lidocaine, even though talking to some of my colleagues or other anesthesiologists, they swear by it, but I've not seen a smooth nebulized lidocaine.
Okay.
So the other way, if you have somebody with a nice anatomy, the airway blocks work well. And what you're doing is you do have to get the glossopharyngeal nerve. So do keep in mind that viscous lidocaine. Usually, if you do the blocks, all you have to do is that 15 cc's of 2% viscous lidocaine that you have them gargle for a minute and spit out. And you have them spit out just because of the toxic level. Just as an aside, if you're doing a TEE, have them swallow it because you want that esophagus to be numb. But when they swallow it, it doesn't help you with the trachea, but it adds to toxicity.
Okay.
So you go ahead and do that, or the lollipop. I think the viscous lidocaine works better. And then you do your blocks. So the one block that you do is you get the superior laryngeal nerve and the recurrent laryngeal nerve. So I usually start with the recurrent laryngeal nerve, and that these are branches of the external laryngeal nerve and the internal laryngeal nerve of the vagus that you're numbing up. So for the recurrent laryngeal nerve, you want to go through the cricothyroid membrane, and you could feel everybody on the cricothyroid membrane that you have. That's where you do your crics as well. And so what I set up is 2% lidocaine in get about 4 cc's drawn up, and you want to get a long 25 or 27 gauge needle. I also get 5 cc's of 4% lidocaine with an 18 gauge needle on the end of that. Now, if you have an angiocath that's like one of the safety ones, then it works very well to use for this. Unfortunately, most of the regular length ones we have are safety ones at Denver Health. So I use an 18 gauge needle.
Short, is that, or is that why you
Short is like the 1 inch. You have the super long needles that are like 2 inches that are not the safety ones, but all the regular 1.25 inch at Denver Health are safety angiocaths. So what I was trying to say is that when you put that inside the cricothyroid membrane, it's nice just to have a catheter as opposed to an 18 gauge needle, because if there's any problems, it causes less damage. But I use an 18 gauge needle. Some of my colleagues like to use a smaller needle because it causes less damage. I use the 18 gauge because I inject it fast. It's very hard to inject through a 20 or 22 gauge needle and takes longer. I stabilize my hand, inject fast. The patient coughs. I try to get them not to cough, but they will cough eventually, hopefully once the needle's out, and it spreads it around. So anyway, the way I do it is I will take the 4% lidocaine is for the going through the cricothyroid membrane. But what I do is I take a little bit of that 2% that I'm going to use for the superior laryngeal nerve and just put it at the cricothyroid membrane to get a little bit of a skin wheel. Okay. And I use that with a 25 or 27 gauge that's on the other syringe for the superior laryngeal nerve block. So I go ahead and get a little skin wheel to the cricothyroid membrane with a 25 or 27 gauge needle, 2%. And then I stabilize my hand and go ahead and advance this 18 gauge aspirating through the cricothyroid membrane until you get air. It's very obvious when you get air. Somebody's holding the head. I inject this 5 cc's as fast as I can and tell the patient, don't cough, don't cough, don't cough, and somebody's holding the head. And hopefully most of the time I can get it all in before they cough. You pull it out, and usually the patient coughs. You actually want them to cough because it spreads it around. You're trying to avoid them coughing with the needle in there.
Neck, right.
Yeah, so that gets everything below the vocal cords and numbs it up pretty well. Then I go ahead and get the 2% lidocaine that I've set up with a 25 or 27 gauge needle, and you go in your hyoid bone. You could feel the hyoid bone, and you go to the corner of the hyoid bone on
And of
each
course,
side.
immediately my hand goes to my neck and I start feeling for my
Yeah, exactly.
help
And you
ourselves.
feel your hyoid bone, and you can figure it. You could have a wiggle right or left if you have your hand like a C on top of your neck, and you have your thumb and your index finger on the cricothyroid membrane. And what you want to do is find the cornu, so the end of the hyoid bone, because the superior laryngeal nerve goes right through there. So you go ahead and you don't need to do a skid wheel because you just have a 25 or 27 gauge needle. And you go ahead and it should be pretty superficial and advance until you hit bone. And once you hit bone, you're on the hyoid bone, and you go ahead and inject. I usually do 1.5 cc's on each side, and that numbs up above the vocal cords very well.
And when you do those, then you don't need to do the drip lidocaine down the fiber optic or down the scope as you're
Correct.
in the scope because everything's already numb.
It numbs it up incredibly well above and below the vocal cords.
But you
Yes.
have to have decent anatomy. Can you do that in an emergency situation, or I guess it just depends on the emergency?
Well, one, it depends on the emergency, and usually, no. Usually, usually no. And the other problem too is you might be able to do the cricothyroid membrane one because most people that trachea down at that level are pretty and not involved. So you could probably do that for below the vocal cords. Usually, if they're in emergency, their airway above that is going to be distorted. And it does take a few minutes to go ahead and get this done. So for an emergency, it's usually pretty hard to get this done. Usually I do the dripping through the epidural catheter and the atomizer. You cannot do the viscous lidocaine in an emergency. Most of the time they cannot gargle. So I'll do the atomizer, and then I'll do the epidural through the catheter. And if, they can take any sedation, then I go ahead. Once again, sedation that does not take respiratory drive, such I like Precedex infusion. That works very well. Adding a touch of ketamine. And I do mean a touch because if you are adding more than 20 or 30 milligrams of ketamine, it's going to increase salivation and completely, blur your image.
Even after glyco?
Even after glyco.
Oh, okay.
Even after glyco. Yeah, 20 to 30, there's not enough glyco to dry them out. And the other thing to think about is if you're doing these blocks or you did go ahead and numb them, you probably want to suction the airway before you go ahead and put that fiber optic or have somebody with suction, because that lidocaine is going to be sitting there obscuring your view when you go ahead and advance the fiber optic. So I usually try to suction them or have somebody with a suction catheter in their mouth when I go ahead and do the fiber optic. The other thing you have to do sometimes, like I said, make sure somebody's holding that airway midline. And then sometimes you do have to get somebody to even pull that tongue out of the way if they're swollen to get out of the way. And now just with this one gentleman that we did, his anatomy was so distorted, that one with the abscess.
Yeah.
Yes, that I let the resident try. We couldn't see anything. I tried, and I saw right away it was very distorted. Going through the nose is a straighter shot. And I was, after we tried multiple times, even me trying through the oral airway, went ahead and went through the nose, which was a direct shot, and we were able to get that through there.
Did you actually see the anatomy, or was it kind of like go blindly in and boom, there it is? Or sometimes I know I've gone into the esophagus and pulled back because I just can't see anything, and then just pull back slowly. No.
So once you get to the posterior pharynx, and now the thing you're looking for is sometimes you don't see the anatomy, but you have the patient breathe. You're looking for air bubbles, and you guide to the air bubbles. So sometimes it's impossible to see, and you just follow those air bubbles. And if you follow the air bubbles enough, you just keep on having them breathe, you will eventually find the vocal cords back there. And with the nose, you don't have to worry about getting the tongue out of the way because it is a more of a direct shot to go back there.
Wow. Well, this has been really fun. Any last tips or tricks or anything that you'd want to share with the listening or viewing audience?
Well, I want to continue, if we do have time, with this gentleman. So we went ahead and finally got the tube through the nose, and CO2 was there, went ahead and induced the patient. Everything's going fine. And I'm standing there and I smell SIBO. And I'm like, why are we smelling SIBO? And the resident inflated the cuff and the cuff felt fine. And I'm like, no, something is wrong. We are smelling SIBO. And then we can hear a leak. So anyway, we figured out something was obviously not correct with the cuff. And we had to go ahead and change this tube. The OMFS attending, because it was his case, said, well, your resident did not check the cuff. And I was, well, actually, I'm the one that checked the cuff. And I did check it. And the other thing that I did forget to mention is that one way to soften up the tube is to put it in warm, normal saline before you go ahead and load it up to the fiber optic. Again, the reason I remember that is I checked the cuff on this nasopharyngeal airway, on this nasal tube when it was in the warm, normal saline. So I specifically remembered that. So now we're sitting there and I'm kind of like, well, can't you just operate with the leak? I was kind of joking, but I'm like, I know. And I even suggested that. And he was like, well, one, no. And two, he literally made us change to a TIVA until we were figuring out what to do because he didn't want to inhale SIBO.
Yeah, I guess it's okay.
So then we're sitting there and I'm thinking, okay, me and the resident were having this discussion and we're like, well, we have to change it. And we cannot just extubate this guy because we're not going to be able to reintubate him. So we took a soft Cook catheter, and it's the green one. I don't know if it's always green, and went ahead and advanced it through this nasal tube as far down as we could, and went ahead and pulled out this nasal tube. And luckily, successfully, were able to, through this Cook catheter, advance the other well-lubricated tube through the nose and check the cuff, made sure everything was fine, and went ahead, were able to secure the airway. Now, the interesting part about this, and I've got a great picture, is that it turns out that the pilot balloon at the side of the T-tube was kinked. So it's sitting there going, okay, well, it was kinked. And that basically was the problem. I thought it was defective. Well, my resident goes ahead and unkinks it, and it works fine. So the problem, what happened is somehow when it got advanced through the nose, that pilot balloon where it attached, the little line there where it attached on the ET tube got kinked when we went ahead and advanced it. There was nothing wrong with the cuff, the pilot balloon. It just literally got kinked when we went ahead and advanced it. Just something to be very cognizant of is try to make sure that pilot balloon, where it attaches to the ET tube when you advance it, does not get kinked. It literally just got kinked as we advanced it.
But isn't the pilot balloon where it attaches up high, at least?
Right. But I'm trying to describe, how would you describe where it attaches to the ET tube? You have the ET tube and it attaches down here at the end here. It was kinked right there at the attachment of the ET tube.
Wow.
So
and
that little,
so you couldn't really even see it, or
we cannot see it
because it was the tube. Yeah.
Yeah, could we have pulled it to unkink it? I'm not sure we could have done anything different. First of all, we didn't know.
Right.
But now when I go ahead and advance it, I'm very aware of making sure that where the pilot balloon is, where it attaches, that it's free and clear and it's not getting kinked as we go ahead and advance it.
Wow. What a great case. So many great cases. I'm glad I do peds.
Yeah. What do you do for peds? I'm kind of curious. How do you do a difficult airway if you don't? I know there was, I think, Dr. Lane at Children's. He used to do, I remember doing awake fiber optics with him. I was a resident. It was many moons ago. But I don't remember seeing it that often. What do you do for kids for a difficult?
We rarely do them awake because most kids are not going to tolerate a lot of the things that you even describe. You can't even, depends on the age, you can't get them to necessarily cooperate. It is, I think, one of the reasons why we fall back on doing the local anesthesia nebulizer, because it's one of the few things we can do that most kids will tolerate. We do a lot of, the lube stuff. A lot of it is really just keeping them breathing spontaneously with an inhalational induction, if possible. Although most of the studies from the PDIR, which is the pediatric, what does it stand for? The Pediatric Difficult Airway Registry, which is it's now multinational, but multi-institutional group that monitors all the difficult airways, of the hospitals that are part of it, which includes Children's Colorado. It includes Stanford, and it was started at Children's Hospital of Philadelphia. But it's very rare that a child is actually difficult to ventilate. It's rare.
Even like Pierre-Robin syndrome?
Even in Pierre-Robin, it is not, it definitely occurs. Well, the worst of the Pierre-Robins, no. I mean, you just want to keep them breathing spontaneously, but most of the time we end up inducing them with just enough to keep them breathing spontaneously. And just enough that we try and do whatever localizations that we can. And a lot of times, again, that as much as I agree with you and I don't think it works very well, we will still use nebulized lidocaine. And it's interesting what you said about tetracaine. I may look and see if we even have that and if that would be possible to try. To try and minimize the amount of anesthetic that we would need to give, but it's really rare. I do remember though, in some of our and again, this was back in Colorado where we did, I think, a lot more Pierre Robins than we do here. And again, with Dr. Lane, a lot of times babies will tolerate an LMA pretty well. Not all of them, but some of them really, you can put an LMA in. And then you can then now you have an airway and you can induce them through that, keep them breathing, or whatever you need to do. And then you can intubate with the scope through the LMA. So that's the other thing that we do, but it's really uncommon. It's really uncommon to do a true awake intubation in most children. And the few that I've ever seen, I mean, they're an extremis. And so it's, you're just doing what you can do to get an airway. So, but LMAs will sometimes do. And like I said, little babies can often, I mean, I've seen them just suck away on it, but I've also seen them spit it out. So it depends on the baby, just like so many things, depends on that baby. So.
Well, I mean, just like you're saying, the safest way is always to keep the patient breathing on their own. In adults, obviously, we can't do an inhalation induction. I mean, you can, but it could be very challenging.
Yeah.
But just like for you and babies, keeping them breathing on their own. If patients breathing on their own, then it's probably better to get them intubated awake if you have any concerns.
So the other thing that's really interesting, and I'll tell you this because this has been increasingly part of what the groups that are involved with the registry have found, is that in children, specifically in children, most of the time for most difficult airways, it's actually okay to not have them breathe by themselves, because what happens is there's actually a higher incidence of complications if we're doing just an inhalational induction and then trying to do their airway, because if all you have is gas on board, the moment you take that gas away, they're breathing it out, they get light, they go into laryngospasm, and that's actually more of an issue for them than losing their airway. So they recommend either switching to a TIVA or, deepening them some other way, whether it's, again, using a lot of local. I mean, I've definitely done local through the scope. I love this idea with the epidural that you mentioned. I'm definitely going to try that in the future to try and get
looks great.
And yeah, better, because some of the kids, are young enough, they can't even do the viscous lidocaine for you, or they might be able to suck on your lidocaine lollipop. I like that idea, but it's bitter. Isn't it really bitter?
Oh, it tastes awful. Yeah, I tell the patient it tastes awful.
Yeah. In their mouth.
Yeah. Maybe you guys can invent some strawberry flavored one or something.
Strawberry flavored lidocaine ointment.
Yeah.
Pharmacy.
Yeah, right.
Not sure how well that would go. But yeah, so that's what we end up doing. And with younger kids, we do a lot of scope through the LMA because it seems to be safer. And again, not just my experience, but also what's been borne out with the multi-institutional study that especially young children, little small children, I'm talking more like infants and neonates, they drop their sats so fast, they have no reserve. Trying to get them, you can try high flow oxygen or you can try nasal cannula to give them additional sources of oxygen while you're intubating. But sometimes, if you can just get an LMA in, now you have a secure airway, and you can do whatever you need to do, and it can take as long as it needs to take in order to get that tube in. So we've got spoiled, especially since you and I started. When I started, I don't even think we had LMAs. I think when you started, LMAs were being used, right?
I think they just started using them because when I was at UCLA, I used to lecture around Los Angeles on LMAs because it was a new thing. And then, we still, even in adults, we do Well, first of all, we have the intubating LMA that you could intubate through, and we do fiber optic through the LMA as well in adults breathing. I mean, once they're asleep, so it's also practiced in adults. But if you have a distorted anatomy, you got to be a little concerned.
All this pus
exactly
in the teeth. I don't even know how you get an LMA in someone with a huge abscess. So
right.
Well, Dr. Juels, Alma, this was great. I really enjoyed talking with you. And any other last minute things that you'd like to say before we sign off?
No, it's been great talking to you. Like I said, you've always been my mentor, and you've done incredible things in the anesthesia world, and I've always enjoyed following your progress over the years. So it's been nice to be able to catch up this way.
Well, great. And it was great. Yeah, it's great seeing what you've been up to as well. So thank you all for joining us for another episode of Vital Times, the podcast, the California Society of Anesthesiologists podcast. This is Dr. Rita Agarwal, your host. And if you have any questions or comments, please let us know. Thank you.